aku sekarang ya. Video umaru itu. Okay,
Hello, good afternoon, everyone. Hi, my name is Dr. Leong. I'm a pediatric cardiologist from Institute Jantung Dara. And today we're going to have an interesting session. It's on single ventricle physiology. And we're going to have a very interesting speaker to talk about single ventricle physiology. But before we move over to the talk, I would like to have some housekeeping announcement. Firstly, I'll need everyone to mute your mic. All right, you can show your screen, you can switch on your camera, that's fine, but please do not switch on your mic. All right, this will disrupt the lecture. And the second thing is, at the end of the lecture, we will flash a QR code. Please scan the QR code using your camera or your QR code reader, not the MMA app, but the QR code reader, so that you can claim your CPD points. All right. So this week we have an interesting talk. It's on single ventricle physiology. What is it? What does it entails? A lot of times we classify them as complex congenital heart disease, but now we would like to put a name to the diagnosis and call it a single ventricle physiology. And what we do with this physiology, can we offer anything? Can we do surgery on them? And what happens after we offer surgery to this group of patients? To give this talk, we have Dr. Martin Wong. Dr. Martin Wong is a consultant pediatric cardiologist and a head of pediatric cardiology unit at Pusat Jantung Sarawak, Kuching. And he's a very versatile pediatric cardiologist. He can do intervention, he can do imaging, he can do MRI. He's indeed a very versatile cardiologist. And he always amazes me with his way of putting complex concepts into very simple logic. So today, I think you will be mesmerized as how I get mesmerized by him all this while. And he's going to talk to us about single ventricle physiology. Over to you, Martin.
Thanks very much, Leong. Yeah, so today our topic is single ventricle, which is quite a difficult topic to discuss about it in just a short period of 1 hour. I will try my best to make it as simple as easily to understand as possible. So basically, single ventricle is not a single disease, single type of congenital heart disease, but it's a group of various different type of congenital heart lesion, usually complex, but they share a similar characteristic, which is a heart that is lacking of two well-developed ventricles. So basically, they only have a functional single ventricle, or sometimes we call univentricular heart. It accounts about 10% of all the congenital heart disease combined. And as I mentioned, it is highly heterogeneous. There are many different groups of congenital heart disease that can be categorized under this big umbrella of single ventricle. I just list down some of the common one here. The one that is well known is hypoplastic heart syndrome. Then you have this whole lot of this whole group of complex condition. I will try to make it as simple as possible. I'm sure everyone knows what is hypoplastic heart syndrome, which is characterized by a very underdeveloped left side of the heart, frequently associated with a very hypoplastic of the arch. And then it is the right ventricle that is a dominant ventricle that produces the whole body, including producing the systemic circulation via the PDA here. Yeah? But there is another big group of a single ventricle where there is some problem with this important portion of the heart called atrioventricular connection, which is the junction between the atrium and the ventricle. Most of the single ventricular, they develop as a result of abnormal development of this part of the heart, the atrioventricular connection. It can be ranged from a double inlet situation where both the atrioventricular valve empties into a single ventricle here, or it can be atresia of one side of the atrioventricular connection, like in this case, there is an atresia of the tricuspid valve, resulting in an underdevelopment of the right ventricle. So you only have one dominant left ventricle here. It can also develop as a result of instead of two separate atrioventricular valve, you have a common atrioventricular valve. Sometimes we call this atrioventricular septal defect or AV canal defect. Yeah. So the first one is a double inlet ventricle where both the inlet or both the atrioventricular valve empty into a single dominant ventricle. More commonly than not, this single ventricle, dominant ventricle is actually left ventricle in morphology or in embryology. But frequently there is a small rudimentary chamber, which is the right ventricle at the side of this dominant ventricle, which is connected to a connection here that sometimes we label it as a VSD or bulboventricular foramen. Now, this is just a general category. In terms of the outflow anatomy, it is highly variable. The aorta and the pulmonary artery can be connected in a various different ways. Sometimes the aorta can be connected to the main ventricle. Sometimes it is a pulmonary artery that is connected to the main ventricle. This will affect the physiology, which I will elaborate subsequently. Yeah? Now, when one of the AV valve is atretic, then you have a condition like tricuspid or mitral atresia. Depends on which side of the AV valve is affected. If it is the right side that is affected, then it is a situation of tricuspid atresia, where the corresponding right ventricle will be underdeveloped. If it is left side, then we call it mitral atresia, in which then the left ventricle will be underdeveloped, the dominant ventricle will be right ventricle. And finally, as I said, if this AV connection is guided by a common valve, then we call this AVSD. But in most cases for AVSD, you have two well-developed ventricles, just like the commonly encountered situation, especially among patients with Down syndrome. You have a complete AV septal defect or AV canal defect. They have two well-developed ventricles. They only have single ventricle when this connection is unbalanced, where most portion of the AV valve is committed to predominantly to one side of the ventricle, resulting in underdevelopment of the opposite ventricle. And so it can be right-sided dominant unbalanced AV septal defect or unbalanced left dominant AV septal defect. So this kind of unbalanced AVSD is very common in a group of conditions called heterogenicity syndrome or isomerism, which sometimes I think you have encountered this term before. Basically, this is a very complex organ malformation syndrome that not only affects the heart, but also the other organ, body organs such as the liver, the lung, and the gastrointestinal tract. And this whole group of heterogenicity syndrome is frequently associated with single ventricle, especially the single ventricle of unbalanced AVSD variant. So we are not going to go into detail of this heterogenicity syndrome. You just need to remember that this heterogenicity syndrome is frequently associated with single ventricle. Yeah? In addition to the three main categories of single ventricle that I have mentioned, occasionally we do encounter some of the lesions that sometimes have associated single ventricle, like pulmonary atresia intact septum. Now, in majority of patients with pulmonary atresia intact septum, they have two well-developed ventricles. Only in certain variants, we call it unipartite, where the right ventricle is severely underdeveloped. Then we call this, we categorize this under the single ventricle category. Yeah? Similarly, in epsilon anomaly, majority of the mild and moderate epsilon anomaly, they are not single ventricle. They are two ventricles. But in very severe form of epsilon anomaly, where there is extreme apical displacement of the tricuspid, resulting in huge portion of the right ventricle become atrialized, then you have a tiny portion of the true right ventricle that is left behind. So because these are tiny portion of the right ventricle may not be able to function normally, then we categorize them as a single ventricle. Yeah. So you can see that the single ventricle actually is not a single disease, but a huge different group of various form of complex congenital heart malformation that share a similar characteristic, which is they only have one functional ventricle instead of two functional ventricles. So not only the anatomy is as variable as I described just now, even the physiology is extremely heterogeneous. So in order to understand the physiology, you really have to analyze the malformation bits by bits. Yeah? So these are the key questions that we have to answer when we assess a patient with a single ventricle. Yeah, the most important question, the first question we need to ask is there any outflow obstruction? Yeah? So whether there is a pulmonary outflow obstruction, such as a situation of a patient, the single ventricle have a concomitant pulmonary stenosis or even pulmonary atresia, yeah? Because these will cause reduced pulmonary blood flow, which will consequence a clinical manifestation. Is there any systemic outflow obstruction, such as coarctation or aorta or a hypoplastic aortic arch, or even in the extreme form, like in the hypoplastic left heart syndrome, they frequently have aortic atresia where there is totally no antegrade outflow into the systemic circulation from that single ventricle. Sometimes a restricted interventricular communication can behave like an outflow obstruction. I will give some example after this. So the very first question is there any pulmonary outflow obstruction? Is there any systemic outflow obstruction? And then the second question is there any pulmonary venous inflow obstruction? Yeah. So this is frequently seen in patients with anomalous pulmonary venous drainage, but occasionally can be seen also in patients with stenotic epivalve with restricted ASD. And the third question then we need to ask is if there is none of the above, no obstruction to the outflow tract, no pulmonary venous obstruction, then this patient will have the next important physiological changes that will happen over the next few weeks after birth is changes in the pulmonary vascular resistance, because we know that as during newborn period, we have all the normal baby will have a very high pulmonary vascular resistance, which will gradually drop over the next over the next 2 to 6 weeks, by which the pulmonary resistance becomes very low with the corresponding increase in the pulmonary blood flow. And if there is unrestriction in terms of there is no outflow obstruction, then this will lead to too much flow go into the lung and onset of clinical heart failure. Yeah? And finally, is there any major epivalve regurgitation? Yeah, let's go through one by one. Yeah? So in a single ventricular systemic outflow obstruction, the classic example is a hypoplastic left heart syndrome. As you can see from this diagram here, the left ventricle is underdeveloped. This is frequently accompanied by also a stenotic mitral valve and outflow obstruction to the aorta. And some even have a total atresia of the aortic valve, and frequently accompanied by very hypoplastic aortic arch. So the dominant ventricle that provides the pump function actually is the right ventricle. So this right ventricle actually had to support two circulation. Yeah, the first circulation, of course, is the pulmonary circulation here, but it also had to support the systemic circulation via the ductus arteriosus. So it is very important for the ductus arteriosus to remain patterned and wide to provide unrestricted flow to supply the whole systemic body circulation. In fact, the coronary circulation is also produced by this ductus arteriosus because the blood had to pump across the PDA, retrograde into the aortic arch, and then coming back proximally into supplying the coronary circulation. Yeah. So in this situation, the high pulmonary pressure is inevitable. You need very hard to maintain the high pulmonary artery pressure in order to maintain the systemic perfusion. In addition, there is also obligatory left to right shunt across the ASD. Yeah? So ASD become very important in this situation because when the pulmonary venous return come back to the left atrium, it has no way to go because the whole outflow from the left heart is obstructed. So it had to pass shunted across to the right side of the heart across the ASD. If the ASD is restricted, that impedes the pulmonary venous return. Then clinically, it will behave like a patient with an obstructed pulmonary venous drainage. Yeah? So you can see that a single anatomical description of this hypoplastic left heart syndrome has a multiple physiological consequences in terms of systemic perfusion, high pulmonary artery pressure in order to maintain the perfusion, and also obligatory shunt across the ASD. Yeah? How about pulmonary outflow obstruction? The classical example is pulmonary atresia intact septum, like illustrated in this diagram, where there is atresia of the pulmonary valve here with the corresponding underdevelopment of hypoplastic right ventricle. Yeah? So because the RV is hypoplastic, this is categorized as a single ventricle. In this situation, there is no antegrade flow across the pulmonary valve because the valve is atretic. So the pulmonary circulation becomes ductal dependent. Yeah? It depends on the patency of the duct to maintain the pulmonary circulation. Yeah? So this is very important. Again, this is another situation where the AAC shunt becomes very important, but this time is from right to left, yeah, because the systemic venous return had to pass through the AAC to go to the left side of the heart, then enter into the aorta, from there through the ductus arteriosus, then enter into the pulmonary circulation. Yeah? Now, as I just now mentioned, that sometimes a restricted ventricular communication can behave like an outflow obstruction. We take for the this example here, where this patient have a double inlet ventricle, where both the tricuspid and mitral valve empty into this dominant left ventricle. The right ventricle is underdeveloped, just a rudimentary chamber connected by a small bulboventricular foramina here. Yeah. In this case, the artery are connected in a transposed manner, where the pulmonary artery is connected to the main ventricle, whereas the aorta is connected to the rudimentary chamber. If this VSD or the interventricular communication is very small, then there is a restriction to the aortic flow. So this will behave like a patient with an aortic outflow obstruction, just like a patient with hypoplastic left heart syndrome, where there is not enough blood perfused antegrally into the aortic outflow. So some of these cases can behave and have a similar presentation like a hypoplastic left heart syndrome, where they will develop cardiovascular collapse when the ductus arteriosus is closed. Yeah? Similarly, this is the other way around, a patient with a tricuspid atresia with restricted VSD. Yeah? So in tricuspid atresia, the systemic venous return had to pass over to the left side of the heart, and from there, you have to go through this VSD in order to enter into this rudimentary RV, in order to enter into the pulmonary circulation. Yeah? If this VSD is very restricted, then you have a very reduced pulmonary flow. So clinically, it will behave like a patient with a severe pulmonary outflow obstruction, like a case of pulmonary atresia intersectant. In some situations, it can be ductal dependent as well. So ventricular communication, restricted communication can behave like a patient with outflow tract obstruction. Now, just now we also talk about obstructed pulmonary venous drainage. This is frequently happening in patients with right isomerism heterotaxis syndrome, where the pulmonary venous drainage is abnormal. Some cases, they can drain inferiorly via this vertical vein, which pierce the diaphragm and enter into one of the portal venous system, yeah? Either into the portal veins or inferior vena cava. And along this pathway, it can get obstructed. When you get obstructed, then you get a severe pulmonary venous congestion. And the baby usually will develop severe respiratory distress soon after birth because of the obstruction of the pulmonary venous drainage. And sometimes they go into acute pulmonary edema. So just now we talk about a lesion with outflow obstruction or pulmonary venous obstruction. Let's say you have a single ventricle like this diagram here, where there is totally no outflow obstruction. Yeah, so this is example of the double inlet ventricle, where this single ventricle receive the opening from the mitral valve and the tricuspid valve, and then from there the pulmonary artery and the aorta all come out from this single ventricle. Yeah, and there is no obstruction. So initially after birth, the baby will be all right because there's no outflow obstruction. But as we all know that when after birth, there is gradual progressive decline in the pulmonary resistance. Yeah? This will result in progressive increase in the pulmonary flow, because when the pulmonary resistance drops to a very low level, there is a preferential blood flow into the lung instead of going into the aorta, which has a very high resistance. So over the course of 2 to 6 weeks after birth, you have a situation of pulmonary overflow. The lung will get overflooded by the blood, and then you start to develop symptoms of congestive heart failure. So congestive heart failure will occur a bit later if you don't have any outflow obstruction. In fact, there is in common single ventricle, you have this common missing physiology where you see all the venous return either from the systemic vein or pulmonary vein, they all enter into this single ventricle. And then from there, it will get distributed between the systemic circulation and the pulmonary circulation, the amount of which, the ratio of which strongly depends on the resistance in your lung. Yeah? Because the systemic vascular resistance is more or less fixed. It is a lung pulmonary vascular resistance that will change after birth. Yeah? Initially, this resistance is very high, so you get almost like a very balanced kind of situation. That's why these baby are when immediately after the neonatal after birth, they are quite all right because the circulation is relatively balanced. But once over the next few weeks, when the pulmonary resistance gradually drop, then there is a preferential flow go to this direction where the pulmonary flow becomes higher and higher at the expense of systemic circulation. So there is less blood go to the systemic side. Late. Yeah. So this actually will affect the clinical presentation. Yeah? So ideally, we want all the single ventricle.
We will wait for you.
I will prefer the single ventricle to be in a balanced state where there is a equal amount of blood going into the systemic circulation and pulmonary circulation. In a balanced state, then you will have something like because the blood had to mix around, so you will get a saturation, oxygen saturation of around 80%, where there is an equal distribution of the pulmonary and systemic circulation. But as the resistance getting lower and lower, so you have a more flow enter into the pulmonary circulation. So QB is denotes the pulmonary blood flow versus QS, which is the systemic blood flow. So once the pulmonary flow becomes higher and higher, then you can see that the oxygen saturation become more because now you have a more higher portion of the pulmonary venous return that contribute to the total venous return that this single ventricle is receiving. Yeah? So you get more proportionate, more pink blood coming back mixed with the less amount of blue blood. So overall, the systemic circulation actually increase. Yeah. So by knowing the oxygen saturation of this baby, we can roughly estimate how much is the pulmonary blood flow versus the systemic blood flow. Yeah, if the patient is very pink, like saturation of 90%, it means that the pulmonary flow is actually 3 times the amount of systemic blood flow. Is this really good or not? Actually, this is not good because then you have to look at the total volume that this single ventricle has to handle. Yeah? In a one-to-one manner, this single ventricle is already volume overload because it had to handle 2 circulations. Yeah? So in one-to-one manner, this single ventricle is already handling double the amount of volume compared to a normal heart. When you have a 3 times systemic pulmonary blood flow versus a 1 time systemic blood flow, in fact, this single ventricle actually handling 4 times the normal cardiac output. Yeah, this is a tremendous amount of volume overload on this single ventricle. So invariably, this patient will have a heart failure. So in a single ventricle situation, you have in a baby, we have single ventricle situation with very high oxygen saturation. This is actually not a good sign because it means that there is too much flow go to the lung and then resulting in severe volume overload of the heart. Yeah? In fact, the best is probably one-to-one situation where the oxygen saturation around 80%. So this is probably the ideal kind of oxygen saturation that we should target in all patients with single ventricle. Yeah? On the other hand, if the patient has some kind of pulmonary outflow obstruction that result in less flow go to the lung, overall the heart no need to handle so much volume, so they do not have problem with heart failure, but they will have problem with oxygenation. Yeah? The saturation will be low because not enough blood going into the lung to get the oxygenation. So with this, I hope you probably now can understand why sometimes we do not like all these patients to be too pink, because too pink actually means that too much volume overload of the heart. So this brings out to what is the best physiology for single ventricle. The ideal single ventricle physiology should be they should not have any obstructed systemic outflow. Yeah, because the systemic outflow is important to maintain the end organ perfusion. Yeah, they should not have any obstruction to the pulmonary venous return. Of course, the valve ideally should be competent. If there is an obligatory interatrial shunt like ASD in the setting of hypoplastic left heart syndrome or tricuspid atresia, ideally we want the interatrial communication to be as wide as possible. So it is important to have a large ASD, good ventricular function, and a balanced pulmonary to systemic flow ratio. How to maintain this balanced situation? The best is when there is some kind of mild or moderate obstruction to the pulmonary outflow that reduce restrict the flow to the lung, because we know that the pulmonary resistance will drop after birth. So without any restriction, it will overflow the lung. So with some kind of pulmonary stenosis is the best situation to maintain this kind of balance pulmonary to systemic flow ratio. So I spent a lot of time explaining about this physiology because it is important to understand the physiology so that you can understand why some of these patients have a bit different clinical presentation. Yeah? So if you know the anatomy and the physiology, then you can predict which direction this patient will go after birth. Yeah? So if let's say the patient has some kind of very critical systemic outflow obstruction, say the patient have a hypoplastic arch or have severe coarctation, then you know that this patient can be ductal dependent. So once the PDA start to close, they will develop systemic hypoperfusion, go into circulatory shock, yeah? Oliguria and metaboloacidosis. Sometimes if the condition is undiagnosed, by the time they come to us, they might be in severe shock and multi-organ failure. The clinical presentation can be difficult to distinguish from a patient with severe sepsis. So if you don't have any index of suspicion, sometimes you may treat the patient wrongly as a severe sepsis and they obviously will not respond to the treatment. If the patient have critical pulmonary outflow obstruction, such as a patient with pulmonary atresia, then you know that this patient eventually, once the ductal arterioles are closed, they will go into severe hypoxemia because there's no blood flow to the lung. Yeah? But immediately after because the PDA is still patterned, there is a period of time where this patient can remain relatively well, yeah? Because the ductal arterioles is providing enough flow to the lung. So you have a period of blue but comfortable. Yeah? But if you miss this period, once the PDA closed, then they will go into severe hypoxemia. And then if you don't act on it early by giving prostaglandin to reopen the PDA, then they will go into severe hypoxemia and metabolic acidosis and will decompensate. Yeah? Of course, those with obstructed pulmonary venous inflow, like a patient with right isomerism with infracardiac type of TMDVD, then immediately after birth, they will develop severe respiratory distress soon after birth. Usually, they will need to be intubated soon after birth, yeah, because of the severe pulmonary venous congestion and pulmonary edema. But if you don't suspect it could these things, sometimes they can be treated wrongly as a patient with severe lung problem like PCHC or severe congenital pneumonia. Yeah? So high index of suspicion is important. Now, those without any obstruction to the outflow will present with pulmonary overcirculation several weeks after birth. Yeah? So there is a period of relatively well during the early neonatal period. And when the resistance drops, then they develop congestive heart failure. The typical symptoms of heart failure such as breathing difficulty, failure to thrive, recurrent chest infection. So remember this patient, because of the high pulmonary blood flow, they have relatively very high oxygenation. Yeah? So frequently more than 90%. So clinically, they may not look cyanosis to you at all. The best is those with balanced physiology, as I mentioned just now. Yeah? They usually have some degree of pulmonary stenosis that restrict the pulmonary flow. Usually they have mild degree of central cyanosis between 75 to 85%, and they can remain very well for many years, even without any treatment. So the physiology and clinical presentation of single ventricle is highly variable. All depends on the anatomy, the type of anatomy, and then the physiology. Yeah? So it's not a single disease at all. Yeah? And the management is all highly variable, depends on what is the physiology and the clinical manifestation. Yeah? So how do we assess this patient? Yeah, chest X-ray sometimes can give us some clue. Yeah, so patient with a restricted pulmonary blood flow frequently have a very black lung or oligemic lung because there is not enough blood flow to the lung. Yeah, whereas a patient with unrestricted pulmonary blood flow tends to have a very plethoric lung. So chest X-ray can give you some idea about the physiology. One must not forget to look at other organ when you assess the chest X-ray. Yeah? So this patient, the heterogenicity syndrome frequently have a normal organ malformation affecting other organs such as liver. So such as a central liver like this case, and then you see the NG tube actually go into at the center because the stomach is usually in the central position. And then the lung is oligemic in this case because this patient also had concomitant pulmonary atresia. So when you see this kind of chest X-ray, most of the time you can diagnose this patient have right isomerism, which is frequently associated with a single ventricle and complex intracardiac malformation. So echocardiogram, of course, is the gold standard of defining what is the exact anatomy. So in just a short period of time, it's impossible for me to show you all the echocardiogram of all the various single ventricles. Just to show you some of the typical classical example. This is a patient with hypoplastic left heart syndrome. We can see that the left ventricle is extremely small, just like a small little slit-like cavity here. And then you can see that there is aortic atresia. The aorta is ascending aorta is not connected to the chamber of the heart here, and the ascending aorta is severely hypoplastic. Yeah, this small little structure here is actually the ascending aorta, which is so many times smaller than the pulmonary artery, which is very big here in front of this ascending aorta. And next one is a typical example of patient with tricuspid atresia. You don't see any tricuspid valve here, and then the right ventricle is very hypoplastic here. This is an example of double inlet ventricle where both AV valve empty into this single ventricle here. Yeah? So you have a right and left AV valve, they all empty into this single ventricle. And the next one is a patient with right isomerism. Yeah, this frequently have a AVSD. Yeah? Instead of two separate AV valve, you have a common AV valve. So the atrium empty into this single ventricle via this common AV valve. This one is a patient with pulmonary arterial interceptance. So the RV is severely hypertrophic and the cavity is very small here. And then there is no pulmonary outflow tract because the pulmonary outflow is atrophic there. So these are just a few classical examples of some of the common single ventricle. So sometimes the echocardiogram may not give us all the information that we need. Then we may need to resort to some other form of cardiac imaging to supplement the information. Yeah? So cardiac CT is quite useful, especially if we want to define the this structure that sometimes can be difficult to be seen on the echocardiogram, such as aortic arch problem or pulmonary artery problem or pulmonary venous problem. Yeah? So these are some of the examples of aortic outflow problem, the coarctation aorta here. This patient has complete interrupted aortic junction. So you can see that the ascending aorta only give rise to the branches in the neck. It doesn't go down as a descending aorta. This patient has hypoplastic aortic arch. You can see that the ascending aorta is extremely tiny here. Yeah? Although the descending aorta is well developed. And then anomalous pulmonary vein. Yeah, so this patient have a total anomalous pulmonary vein here. You can see all these four pulmonary veins. They don't drain into the heart, but instead drain superiorly via this vein and empty into the innominate vein. So this is the supracardiac TAPVT. This patient have a right isomerism with infracardiac TAPVT. You can see this pulmonary vein behind the heart. It doesn't empty into the heart, but instead it drains down into the abdomen and then empty into one of the branches of the portal vein here. And here it is get obstructed. Yeah. So this is how the obstruction can occur in most cases of infracardiac TAPVT. It is also quite useful for assessment like the morphology of PDA, because sometimes one of the treatment is standing of the ductus arteriosus. So this CT can actually give us a 3D anatomical view of the ductus arteriosus and also the pulmonary artery. So these are all more for treatment purpose. And finally, cardiac catheterization. The role becomes much less now in terms for the as a diagnostic tool, because we have a very good, we can actually see most of the cardiac structure very well by non-invasive methods such as echocardiogram and supplemented by occasionally by cardiac CT. Yeah? So the role become more of therapeutic roles. Yeah? So I don't want to go much into detail. So I would like to spend the last maybe 10 minutes or so in terms of what is the principle of management of single ventricle, since it is a very complicated topic. Yeah? So before we move on, we have to first of all understand or realize what is the problem with the single ventricle. So you see our heart, the normal human being actually need two ventricles, because we need one ventricle to pump the blood to the lung and the other ventricle to pump the blood into the body. And then the type of blood that handled by these two ventricles is very different. The right-sided ventricle handle the blue blood that contain less oxygen, and the left side handle the oxygenated blood. And we don't want these two type of different blood mixed together, because we want the body to get a blood that have high oxygen content. But if you have only single ventricle, then the blood had to mix. Yeah? So regardless what, the body will have to get some deoxygenated blood. And similarly, this single ventricle had to handle two circulations. So it is invariably a volume overloaded situation. So univentricular heart had two disadvantages. One is cyanosis is inevitable. And number two, volume overloading of the ventricle is inevitable. So it eventually will lead to ventricular dysfunction and heart failure. So this is the two fundamental problems of all types of single ventricle, regardless of the anatomical detail. Yeah. So generally, natural history is very poor. Yeah? So without any treatment, most of them do not survive beyond childhood. Yeah? So 70% of these cases die before the age of 16 years old. Yeah? Of course, the type of the prognosis or the survival, the mortality also strongly depends on the exact detail of the anatomy. It's like hypoplastic heart syndrome, majority don't survive beyond early infancy. Yeah? Whereas a patient with some kind of pulmonary stenosis, which restrict the pulmonary blood flow, may have some long-term survival. So this in 1971, Dr. Fong Tang actually had invented a new operation called Fong Tang operation named after him. And this operation actually had revolutionized the treatment of all single ventricle. Because prior to 1971, all single ventricle, basically, there's nothing much you can offer. Yeah? But this Fong Tang operation actually improved the survival of many of these patients with single ventricle. We look at what is the principle of this Fong Tang operation. Yes? Basically, Fong Tang operation basically divert all the systemic venous return blood into the lung directly. This is possible because our pulmonary vascular resistance in the normal people actually is very low. So because it is very low, you actually do not need a pump to push the blood into the lung. Yeah? So Fong Tang operation actually employ this basic principle. Because of the very low pulmonary vascular resistance, we can actually divert the systemic venous return, which carry the blue blood, into the lung without entering into the heart. Thereby, you don't allow, thereby the heart no longer receive the blue blood from the systemic venous return. So let this heart that have only one ventricle handle the pink blood that come back from the lung and pump the blood to the body. So in other words, we actually something like bypassing the right heart at all. Yeah? Bypassing. So the pulmonary flow after Fong Tang operation is totally passive. Yeah? So the blood flow just flow into the pulmonary circulation passively. Yeah? So this operation is accomplished by doing two anastomosis. One is anastomotic the superior vena cava to the pulmonary artery, and then also connecting the inferior vena cava to the pulmonary artery, usually by using a conduit, yeah, because the distance IVC from the pulmonary artery is very far. So by doing this Fong Tang operation, then you solve these two problems. Yeah? One is to separate the blue blood from the pink blood, thereby release the cyanosis. The patient will become pink after the Fong Tang operation. And secondly, you reduce the volume overload of this single ventricle, because the single ventricle now just need to handle the systemic circulation. Yeah? You no longer need to handle the pulmonary circulation. The pulmonary circulation is handled by itself through this passive flow. Yeah? So we transform the parallel circulation to a serial circulation. Yeah? So in order for the Fong Tang operation or Fong Tang physiology or circulation to work without problem, you need a certain prerequisite. Yeah? So these are the important prerequisites. Sometimes we call it a 10 commandments of Fong Tang. Yeah? Although nowadays we no longer count all the 10 commandments there. So pulmonary artery had to be good size. Because if you have a small pulmonary artery, this passive flow won't happen. Yeah? So pulmonary artery had to be good size, had to be well-developed pulmonary vascular bed, and the pressure in the pulmonary artery had to be very, very low. Because what actually drives the blood into the lung now is your central venous pressure, your CVP, because there is no more pump that pump the blood into the lung. So this pulmonary artery pressure had to be very low, had to be lower than your usual CVP. So we usually take a cutoff point of 15 milligram mercury as a prerequisite to do the Fong Tang operation. If the patient have a pulmonary artery pressure higher than this, then the Fong Tang circulation will not work, yeah, because there is no pump. So resistance equivalent had to be very, very low. Of course, the pulmonary venous drainage had to be unobstructed, because you have a pulmonary obstruction to the pulmonary venous inflow. Then your pulmonary, the antegrade flow into the lung will not happen if you have venous return obstruction. Yeah? Cardiac factor, of course, outflow tract have to be both ventricular outflow and inflow should not be obstructed, because any form of obstruction will increase the impedance to this passive pulmonary flow. Ventricular function had to be excellent, yeah? Because if you have poor ventricular function, this will cause very high diastolic pressure in the ventricle, which will be transmitted into your pulmonary circulation and elevating your pulmonary artery pressure. So all these criteria had to be fulfilled before the patient can be suitable for a Fontan operation. So it is impossible to do this Fontan operation straight away soon after birth, because after birth, the pulmonary resistance is very high, so Fontan will not work. And also because the pulmonary artery and the vena cava veins are very small at birth. So usually we will not do the operation during when they are very young, so we usually delay the operation. Yeah? So usually we do the operation in stages. This is a situation where a stage operation becomes a necessity rather than a preference. Yeah? So usually they need to go through 3 stages. Yeah? 3 stages. Yeah? The first stage, so the stage 1 is usually a preparatory procedure and to achieve all the prerequisites, followed by a bidirectional gland shunt, usually around 6 to 24 months, and then Fontan completion around 3 to 5 years. Okay? So what is the stage 1 procedure? As I say, it is a preparatory stage. Yeah? Preparatory stage means that we want to achieve an ideal single ventricular physiology, so that this patient, after 6 and 24 months later, you will be suitable candidate for a second stage. Yeah? So this ideal single ventricular physiology I have mentioned just now had to be unobstructed pulmonary systemic outflow and pulmonary venous inflow. The circulation had to be balanced and not too much of pulmonary blood flow, etc., etc. Yeah? So obviously, this stage 1 had to be tailored to the individual patient, because every single patient is different, depends on their anatomy and physiology. Yeah? So if the patient have a pulmonary outflow obstruction, yeah, like pulmonary atresia where there is no flow to the lung, obviously you have to secure this pulmonary flow so that this patient can survive to the second stage. Yeah? So usually we start with a prostaglandin to keep the PDA open, and then followed by either a ballot toxic shunt to maintain the pulmonary blood flow, or nowadays, some cases we do stenting of the PDA. If the patient have obstructed pulmonary systemic outflow, then they will require a more extensive surgery. Depends on the nature of the obstruction. If it is a coarctation or aorta, then just go to a surgical repair of the coarctation. But if it is more severe, like hypoplastic left heart syndrome, they will require a more extensive reconstruction of the new aorta by doing a procedure called NOVU or DKS operation. Yeah? So this is a very complicated surgery, so I don't want to touch too much about it. Yeah? Now, how about those patients with too much flow go to the lung? Yeah? When too much flow go to the lung, they will go into heart failure, then the pulmonary artery pressure will become high, then eventually the pulmonary circulation will get damaged, and they will develop pulmonary hypertension. Then they will no longer be suitable to go through Fontan. So it is very important to protect this pulmonary flow by doing a pulmonary artery banding to restrict the flow to the lung. Yeah? So this is usually done around the age of 1 or 3 months, when we know that the pulmonary vascular resistance usually drop to a very low level around that age. Now, those with a restricted interatrial communication, we have to widen it. Yeah? This usually can be done either by balloon subtostomy, or sometimes have to do stenting in this case, or sometimes have to ask the surgeon to create a very big communication by doing an open surgical atrial sepectomy. So once they have done the stage 1, there's usually a period of honeymoon around a few years. So we let the child grow until they are usually around between 8 kilo to 12 kilo. Then we go for second stage, which is a bidirectional gland shunt. Yeah? Bidirectional shunt involves anastomosis of the superior vena cava to the pulmonary artery. Yeah? So half of the systemic venous return now is being directed to the lung, whereas the inferior vena cava still carry the blue blood into the heart. Yeah? So this is the stage 2. And then stage 3 is completion of Fontan, where we will connect inferior vena cava into the pulmonary artery. Yeah? So this is usually done between 2 to 5 years old. So once this is done, we call it total right heart bypass, because all the venous return now go into the lung, no longer entering into the heart. So over the decades, this Fontan operation, there are multiple revision in order to make it more hemodynamically more ideal. Yeah? So nowadays, most of the Fontan are performed either by these two methods. One is using a conduit, extracardiac conduit to connect the IVC to the pulmonary artery, or using a lateral tunnel by creating a buffer within the right atrium to channel this blood upward into the pulmonary artery. And frequently, the surgeon will also create a fenestration to allow a little bit of blood escape into the heart. This is just as a safety measure, to maintain the cardiac output during the immediate post-operative period, because we know that after the cardiopulmonary bypass, sometimes this systemic inflammatory response may cause transient elevation in the pulmonary resistance that may cause a severe drop in the cardiac output following Fontan surgery. So by creating a little bit of fenestration here, it allows a little bit of blood to escape to fill the ventricle so that the cardiac output is maintained. So this is how we do Fontan and the principle of Fontan operation. So overall survival have improved with this Fontan operation. As you can see that before this era of Fontan, very few patients will survive beyond 5 years, but nowadays more than half of the patients can survive beyond 5 years. Of course, the survival depends on the type of single ventricle. Tricuspid atresia tend to fare much better. About half of them will survive beyond 5 years, but hypoplastic heart lung syndrome remain very poor. This is a statistic from Denmark, which is a very well developed, have a very good hypoplastic heart program, and yet you can see even in a very advanced country with a well-developed single ventricle program, the prognosis for hypoplastic heart syndrome remains extremely poor. Less than one in 10 patients survive beyond 5 years. In fact, majority still die during early infancy before surgery. Either they succumb because the condition is so poor, or maybe they have all the bad prognostic pressure that the decision made is not to intervene. So predictor for mortality, of course, type of single, as I said, hypoplastic heart still carry the worst prognosis. Tricuspid atresia carry the best among all the single ventricle. Of course, the birth era, you're born in old period of time, then of course the survival is poor. Low birth weight as usual, prematurity, and presence of extracardiac anomaly all contribute to mortality. But for those patients who are suitable to go for Fontan, you can see that the mortality for the surgery per se actually is very, very small. Sometimes it can be as small as 1 to 2%. This is only applicable for those who are really a very good candidate for Fontan. So most of the mortality are because of the poor selection of candidates. So this is immediate outcome, but late outcome, even for those patients who have successfully undergone Fontan operation, they are actually not cured because the Fontan physiology is just not a normal circulation. This is a statistic from Mayo Clinic. With 40 years follow-up, you can see that only around 40% of the patients survive beyond 30 years. This is for patients who have already completed Fontan. We are not taking into account those who actually died before Fontan. So Fontan actually is not a cure because they have a lot of long-term complications. These are just some of the list. This list is not exhaustive by any means. It's beyond the scope of this lecture for me to go through all these different complications. So basically, why they have a poor long-term outcome, because this Fontan physiology, as I mentioned just now, is just not normal. So it is like something called neoportal circulation system, because now this ventricle, the single ventricle that only need to handle the systemic circulation, actually had to pump the blood through the circulation. So it is no longer like a parallel circulation before the surgery, but it is now in serial. So the blood had to be, the ventricle had to push the pressure out in order to drive the perfusion to the systemic circulation. Then after that, it comes back to the venous central vein. This central vein had to pass through another capillary system, which is our pulmonary circulation, before it managed to reach the pulmonary vein. And from there, it comes back to the single ventricle. So it actually had to go through 2 capillary systems. So if there is an obstruction along any way, the backward pressure will build up, and the backward, particularly at the pulmonary circulation, because our pulmonary circulation, the resistance usually tends to go up gradually as our age increase because of various factors. So over time, the systemic venous pressure, your CVP, had to become higher and higher in order to maintain this forward flow across the pulmonary circulation. And this high venous pressure in your body actually create all sort of complications, like your liver complication, your protein losing enteropathy, your liver cirrhosis. So whatever it is, this spontan operation is still considered a palliative solution. Yeah? So basically, all single ventricle, you cannot cure them. We can only palliate them with a series of operations in order to improve their survival, improve their quality of life, but there is no way to cure them. No way to cure them. They will still come back many years later with all sorts of complications. So in conclusion, single ventricle is a group of a complex cardiac malformation that has a very heterogeneous anatomy and highly heterogeneous physiology. The Fontan operation has revolutionized the care of this patient. Many will be able to survive into adulthood. They require a staged surgical management approach because you can't achieve this Fontan circulation by just one operation. That usually had to go through 2 or 3 operations. And then, despite all this improvement in the surgery understanding of the single ventricle physiology, the long-term outcome remain unsatisfactory due to inherent haemodynamic problem with Fontan circulation. With that, I end my talk here. Thank you for your attention.
Thank you, Martin, for a wonderful lecture. I do have to admit that this is a very complex topic, and I do agree that Martin actually did a good job summarizing a very complex subject into a very succinct lecture of 50 minutes. But do keep your questions coming. If you will look downwards of your screen, there's this chat box. Click on the chat box and then forward your question to us. And we will post it to Martin for him to answer it. All right. Another reminder, at the end of this lecture, we will flash the QR code, and then you can take picture of the QR code using a phone or a QR code reader, and then do register for your CPD points. Everybody who comes and attend this talk will get a 1 CPD points. And then for all your friends who have missed today's lecture, don't worry. This lecture is available in our IGN website, IGN Facebook page. So you can visit the IGN Facebook page and you can revisit this talk just in case you have anything you don't understand. You do a bit of reading and then you can come back again and revisit this lecture. That's fine. You can revisit as many times as you want, and you find that if it's useful, you can share it with your friends. And lastly, I have to apologize because there won't be any handouts because all the slides will be available in the video form in the IGN Facebook page. So please get your question coming in, and then we will forward it to Dr. Martin. To get the ball rolling, I would like to ask first one or two questions to Martin. The first question is that, for example, let's say if I work in a general hospital, and so happens that this patient comes out and the patient is diagnosed, and then I scan the patient and it turns out to be one of the 3 cardiac morphology that you showed us just now, one of the 3. So it shows that this patient has a complex single ventricle physiology. So what should I do? It's 3 a.m. in the morning, I'm on call. So I don't dare to call the pediatric cardiologist in for echo. So what should I do?
It depends on where, because I'm working in Sarawak, so Sarawak is a very big state, so I'm encountering this issue on and off very frequently. So sometimes I get receive a referral from, say, from Miri, which is about 1 hour by flight from Beijing. Yeah, so it is very, very far. So as far as a general pediatrician is concerned, when you encounter not just a single ventricle, just any form of complex congenital cardiac malformation, that the moment you put down the ultrasound probe, you look at the heart, you know that this is an abnormal heart. I think the immediate decision making actually is to decide whether this is a critical lesion, such as ductal dependent, whether this is a duct dependent critical congenital heart disease. It doesn't matter whether it's single ventricle or two ventricle. So there are 3 main groups of critical congenital heart disease that will require prostaglandin. Yeah? One is a critical pulmonary outflow obstruction, where there is no, in the case of pulmonary atresia, you cannot see a pulmonary outflow from the heart. The second situation is there is a critical obstruction to the systemic outflow, like a hypoplastic aortic arch or severe coarctation of aorta. And the third scenario, of course, is transposition, which is not relevant here because transposition is not a form of single ventricle. So you are dealing with these two, yes, duct-dependent systemic circulation or duct-dependent pulmonary circulation. So how do you know? How can you know? Of course, echocardiogram play the most important role. If you can call a cardiologist in, you have to call a cardiologist, even in the middle of the night. If let's say you're working in a hospital where there's no in-house pediatric cardiologist, then but you have somebody who has an echo skill. Yeah? Sometimes our practice my practice in Sarawak is all my pediatricians who are work in any hospital in Sarawak, they have some echocardiogram skill. They can actually record the images and then send the images usually via WhatsApp. And then we can actually look at the images and we can roughly guess whether this is a duct dependent or not. Now, in a situation where your hospital do not have anybody who are skillful enough to do an echocardiogram, then you go clinical. We go clinical. So in duct dependent pulmonary circulation, as long as the PDA is patterned, then the patient will be all right. So how do you know when do you need to start prostaglandin without any affirmative diagnosis? Looking at the oxygen saturation. If the patient oxygen saturation is running 80 plus, there is no immediate danger. You can always monitor this oxygen saturation until the following morning where you can actually transfer this baby to a nearest hospital with a pediatric cardiologist. If the oxygen saturation is less than 70, then this is in a critical situation. Then there is no harm to start prostaglandin empirically. No harm at all. Yeah, of course, you have to watch out for all the side effects such as apnea. Yeah, if the patient develops apnea, you just have to ventilate the baby. For duct-dependent systemic circulation, it is a bit more difficult. Before the ductus arteriosus close, usually the patient has no symptom. There is no symptom. Usually the femoral pulses can be strong when the PDA is still very wide. So it is before the patient develops symptoms, it is very difficult to diagnose duct-dependent systemic circulation like severe coarctation without echocardiogram. It is very, very difficult. But once they start to decompensate, then in the early stage, what is different from the usual severe sepsis is the lower limb pulses is disproportionately weak compared to upper limb pulses. If you encounter this kind of situation, lower limb pulses is very weak, upper limb pulses are very well felt, then you might encounter, maybe dealing with one. The other telltale sign is, of course, a differential oxygen saturation. The lower limb, in most of the duct-dependent systemic circulation, the lower half of the body is supplied by the PDA, which is usually supplied by the blood that contains less oxygen. So usually they have some discrepancy in oxygen saturation between the upper limb and lower limb. So lower limb is usually lower. So if you encounter a patient with signs of hypoperfusion, shock, lower limb saturation is a lot lower compared to upper limb, then you are probably dealing with one, and then you should start prostaglandin empirically. There's no harm to start empirically. So this is how I approach this kind of situation.
All right, that's a great answer. So I got a question from Facebook, right? It says that I've heard of single ventricle in right isomerism. Can patients with left isomerism has single ventricle physiology? Over to you, Martin.
Left isomerism and
yes,
single ventricle, yeah. Right, single ventricle is more frequently associated with right isomerism. Left isomerism is less frequent. Of course, anything is possible, but it is not as common encounter. In terms of the anatomy, it is highly variable, very, very variable. In most situations of right isomerism, you will encounter single ventricle with common AV valve, and then usually many of them have some kind of pulmonary outflow obstruction, such as pulmonary atresia or pulmonary stenosis. Some of them have anomalous pulmonary venous drainage. This pattern is pretty common and pretty uniform among patients with right isomerism. Left isomerism, it is very variable. Majority of left isomerism that I encounter, they are two ventricles, they don't have single ventricle. But anything is possible under the sun. Yeah.
All right. Okay, we have another question. It's from one of our viewer on Zoom. And it says here, this patient has undergone a Fontan surgery.
Yeah, I see the question there. Yeah.
Yeah.
So after Fontan surgery,
is acceptable?
It depends on whether the surgeon create a fenestration. Majority of surgeon create a fenestration. So usually with the fenestration saturation, usually in their low 90s or high 80s. This is the usual acceptable saturation. If there is no fenestration, usually they can saturate pretty well, probably 90 plus. Yeah. Depends on the saturation. Of course, it also depends on the physiology of the fontan. Yeah? If the patient has an ideal fontan physiology where the pulmonary resistance is very low, then the amount of blood that shunt across that fenestration is very little. So they have relatively high oxygen saturation. In fact, low oxygen saturation actually is not a good sign. It just means that the fontan circulation might not be in an ideal state. Yeah? So resulting in a lot of shunting across the fenestration. As I can read the question here. The next question is, as a patient will become more sinus later. Yeah, if the cyanosis is anything less than high 80s, that I will be concerned. Yeah, I will be very, very concerned why the saturation is low, because the purpose of fontan is to make them pain. Yeah? So if they remain very sinus after fontan, something is not right. This patient should be assessed by a cardiologist. Yeah? The next question I can see on the Zoom is hypercyanotic spell common before and after fontan surgery? No, they should not be sinus after surgery. Yeah, they should be relatively thin unless the fenestration is very big, resulting in a lot of right to left shunt, deoxygenated blood entering into the heart. They should not be sinus, in fact. Yeah? How much SpO2 difference between upper limb and lower limb is considered significant for drug-dependent systemic circulation? Usually we use a cutoff point of 5% and more. This is consistent with the protocol that we use for pulse oximeter screening for all the newborn. Any discrepancy more than 5% is considered abnormal. You should consider drug-dependent systemic circulation is as one of the possibility. Of course, the other possibility is PCHC. Yeah. Any other question?
That's good. So coming up, we have another question from the audience. It says here that a patient has a fontan circuit fashion, and this patient has a fenestration, and so happens that the saturation is the patient has a fenestration, and so happens that the patient has a saturation of low 80s. Should I or should I not close the fenestration?
I think this is a higher level kind of question. Yeah? This is among our pediatric cardiologists. Closing the fenestration is one of the options, but before you embark on closing the fenestration, because this is an irreversible procedure. Yeah? So once you close it, there is no way you can reopen it. Yeah? This patient need to undergo a TARAF assessment. Yeah? Usually we have to bring the patient to the cath lab, make sure that the pulmonary resistance is low, the fontan circulation is in the ideal situation. If everything is ideal and the only sole reason that the patient have a low oxygen saturation is too large of fenestration, then yeah, it is one of the options. By closing the fenestration, you can make the patient the oxygen saturation high. But before you do that, you just have to make sure that the patient has an ideal fontan situation. Right? Because if the pulmonary pressure is high, closing this fenestration can cause severe increase in the systemic venous pressure, with all the consequences like protein losing enteropathy, the liver problems long term. So closing the fenestration also lost the access for, in case this patient develops some kind of arrhythmia, will require electrophysiological study. This fenestration actually is a very useful access for the electrophysiologist to put the catheter across into the heart. By closing that fenestration, actually they lost this access, making the subsequent electrophysiological process more difficult, more challenging. So there are two schools of thought. I think some cardiologists will have a low threshold to close all the fenestration, but there's another school of thought that the cardiologist will prefer to leave the fenestration open. But obviously, if it is causing problem, then you may have to close it by transcatheter technique.
So the next audience, he said that from the top, it looks as though the outlook of patients with single ventricle physiology is quite grim. High proportion of them actually died even before they reach adulthood. why do we still offer multiple stage surgery in this group of children?
When you assess a patient, every single patient with a single ventricle, every patient has to be individualized because it is a highly heterogeneous condition. For example, like in the lecture, I mentioned that the tricuspid atrial actually carry a reasonable prognosis. So this group of patients with a very favorable anatomy, favorable physiology, I think it is not. I don't think it is wrong to offer a surgical palliative surgical procedure for them because they can have a relatively good quality of life. Some of the tricuspid atresia under my follow-up, they are 40 plus, they are doing well. So yeah, but if say hypoplastic heart syndrome, then of course it's a different story because the overall prognosis is poor. The amount of resources they have to pour in just to buy a few years of poor quality of survival, I think then then it is quite reasonable not to offer, not to offer. Of course, it also depends on the social economy and the understanding of the parents. Every case has to be individualized management. So you cannot say all the single ventricle are lousy because there are some who are doing very well.
All right. Okay. So last question over here, since time is almost up. And last question says, considering the problems, even with surgery, are the failed ones good candidates for heart transplant?
Yeah, I don't think we have much experience of cardiac transplant for those who failed on time in our country. So generally, we don't have too many cardiac transplant. But generally, cardiac transplant in this group of patients are not very good because they have previous multiple surgery. And then some of them suffer a lot of end organ damages, for example, like liver cirrhosis, protein-losing enteropathy. So they are generally not a very good candidate for cardiac transplant versus another young man with dilated cardiomyopathy where they don't have other comorbidity. So generally, they are not a very good candidate for cardiac transplant.
All right. So the thing we'd like to bring across is that single ventricle is not all doom and gloom. A lot of our patients actually lead a fairly normal life. After palliation, they go to school. Some of them get married. They have normal jobs. They may not be able to do manual labor, but they can do desk jobs like ours. They do perfectly fine. I personally know of a doctor who's a oncologist who has a single ventricle physiology, right? And he's doing fine, and with a little discoloration of the lower limbs, but he's actually otherwise doing fine. So we just want to tell everyone that we still offer palliation for this group of patients because a lot of them still lead fairly satisfactory life. All right. I'm afraid that's all the time that we have for today. I hope that you enjoy the talk. I would like to thank Dr. Martin Wong for demystifying a complex condition, single ventricle physiology. You have done a very good job consolidating everything in one 50-minute lecture. And from the morphology, pathophysiology, the treatment options. And if you have any more questions, we will see how we can reply you through this, through the chat right now. But we will have to end this session out anyway. Again, after this, we'll flash the QR code for everyone to claim the CPD points. If you have missed the QR code, you can go back to the IGN Facebook page so that you can get the QR code. Next month, we have another talk. This talk is on echocardiography on a patient with a ventricular subfield defect. If you're interested in attending this talk, do register for the talk. And then if you missed the registration, fret not. You can still visit the IGN Facebook page and then visit the Facebook page live and join us there. So thank you very much for joining us and see you. And thank you very much, Dr. Martin. Thank you.
Thank you.